Thank you guys for having me this morning. So you might notice I changed the title of my talk. It was Taking Health to School, and someone pointed out that might mean that I was like trying to school you guys, and so I didn't mean that at all. I literally meant geographically thinking about health and school related, so I apologize if I offended anybody. So this morning, I'm just gonna give you a brief overview about how education relates to adult health. And then we'll move into discussing this relationship between school function and child health. We'll spend some time talking about how school environments might actually be harnessed to produce health or to improve health. And then we'll wrap up with just a brief discussion of potential implications for our own clinical practice. So I'm going to start off pretty broad here with a question about what our goals are as pediatricians. You know, what's the point of all this stuff that we do? The AAP tells us that the goal is to achieve optimal physical, mental, and social health and well-being for all infants, children, adolescents, and young adults. And you know, this sounds pretty lofty, it sounds really admirable, but I actually think this absolutely sells us short. I think our goal is to produce healthy adults. And I'm gonna argue that today. Paul Chung, when he gave grand rounds about a year ago, he made that point. But to articulate how I think about this, I like to draw on this framework of the life course theory, and this was articulated by Neil Halfon and Moira Inkelis here at UCLA. And this graphic here communicates that the difference between optimal health in adulthood and suboptimal health is actually what happens here in childhood. And through a combination of health promoting and risk reduction factors, we can actually shift the life trajectory of our patients. So it's sort of up to us to try to make sure that our patients grow into healthy adults. And what you'll notice here is that really small changes in health in childhood are magnified over time and actually sustained throughout this life course. So if our goal is really to produce healthy adults, then we sort of have to ask ourselves, what is the most effective health promotion and risk reduction strategies? What are they? So I'm going to argue today that while all of the things pictured here are critically important, how a child performs in school might be the most powerful factor that shapes their health trajectory. So there's a lot of data to suggest that this relationship exists between education and health, and some of you may be really familiar with this, but I'm going to take a few moments to just briefly give you an overview of what we know already. So one thing we know is that more years of education are associated with a whole host of better health behaviors and outcomes. So what you see pictured here is the effect of 4 additional years of education on mortality, heart disease, diabetes, general health, and the number of days missed from work due to illness. And this comes from one of the kind of more famous research papers in this field by Cutler and Yaris-Mooney. And they looked at this in a national sample of adults over age 25. But the same pattern has been repeated across many samples, across times, across geographic regions. There's also evidence that early investments in education actually might produce healthier adults. So this is another really famous study. This is from the Abecedarian study, or the ABCD study, which was a randomized controlled trial of high-quality preschool for poor children ages 0 to 5 in North Carolina in the 1970s. And what they found was that 30 years later, participants who were randomized to the intervention had substantially better health outcomes, particularly among males. So experimental evidence like this suggests that better education might actually produce better health. So you might ask kind of what drives this relationship between education and health. And most people think about 3 main pathways that explain how education during childhood might produce healthier adults. So using national data sets in the US and the UK, again, Cutler and Yarosmuni tested these pathways among white adults and across all of these different data sets, and they sort of provided this summative estimation of how these pathways work. So the first thing they looked at is whether better education gives you more knowledge and also provides you with higher literacy, including health literacy. It's also this idea that more educated people have better problem-solving skills. So they have better health behaviors, and then when health problems arise, they're able to manage them better. They can navigate the healthcare system better. So in their analysis, they found that these cognitive resources accounted for about 30% of this association between educational attainment and adult health. The second thing that they looked at refers to this idea that better educated people have better jobs. So that means they have higher income, they can afford healthier food, they can afford to live in safer neighborhoods, they have better health insurance, and all of this leads to lower amounts of stress, in addition to all of that access to better resources. And again, they estimated in their analysis that these material resources accounted for another 30% of this association. The last pathway is sometimes further subdivided, but in their analysis, they sort of included it as one. Refers to this idea that better educated people have better educated friends. And so those friends have healthier social norms. Those better educated people also have a higher social standing, which shapes how they think about the world and also how they think about their place in the world. All of this leads to lower levels of stress, better coping skills, better social support, and again, those healthier health behaviors and norms. So Cutler and Yarosmuni were able to account for measures of the social network, which they estimated accounted for about 10% of the education health association. They did not find that things like future orientation, locus of control, risk aversion, or discounting played a significant role in mediating this association between education and health. One thing you might notice here is that this does not add up to 100%, right? So about 30% of this association between education and health could not be explained by any of these factors. And this actually remains true today. We still don't fully understand this relationship between education and health, and perhaps more importantly, and what I think is really exciting for future areas of research, is now we're really trying to understand how to leverage this relationship to produce health. So one aspect of education that could potentially be leveraged through policy, for example, is school quality. And so far, I've talked to you about this idea that the quantity of education someone has might impact their health. But surprisingly little is known about how the quality of that education might impact health. So a group of us here tried to tease this out by testing whether the quality of the high school that folks attended could predict their adult health after controlling for a whole host of other factors. So we analyzed data from the National Longitudinal Study of Adolescent Health, which is a nationally representative sample of adolescents followed in over 4 waves from high school through adulthood. The participants came from 80 sample high schools, and the first time that they were surveyed was in the 1994-95 school year. And then they were followed over time, ultimately with another survey in 2007 to 2008, when they were between the ages of 24 to 34 years old. And the neat thing about this data set is it also contains their high school transcripts and results from a school administrator survey for each of these sample high schools. So while we looked at a whole host of quality measures, I'm going to just briefly go through the ones where we found significant associations with both academic achievement and health. And all of these measures came from that school administrator survey. So these included school-wide average daily attendance, which we categorized as high, medium, and low. The percent of students with family members in a parent organization at the school, which again we categorized in these sort of high, medium, and low categories. And then the percent of students who were promoted on to the next grade or who completed high school in the previous year. For our health outcomes, we looked at general health, which we know to be a marker of morbidity and mortality, actually. We looked at obesity, and we looked at whether folks had ever been diagnosed with depression. And we were able to look at measures in each of these domains, both when folks were in adulthood, as well as when they took their first survey, when they were adolescents. So after we controlled for a whole host of sociodemographics and their baseline health status, as well as their individual school performance, high school quality was actually associated with all three of our adult health outcomes. So as we anticipated, going to a high school with lower average daily attendance predicted lower general self-rated health when folks were adults and a higher odds of being diagnosed with depression. Meanwhile, more school-wide parental involvement predicted lower odds of individual obesity in adulthood. So at least with respect to these measures, attending what we considered to be a higher quality school did predict better health. Now, the surprising thing is when you look at promotion on this bottom row here, a higher school level promotion was actually associated with lower self-rated health in adulthood. This was only seen after controlling for the covariates and other school quality measures. So while we don't have a complete answer for why this might be, we think that it's possible that high promotion rates in the absence of individual academic achievement or other quality measures, so social promotion, for example, might not significantly benefit health. Taken overall, these results do suggest that it's not just the quantity of education you receive, but also the quality that might impact your long-term health. So I acknowledge that you're pediatricians here, and maybe you're not moved by my argument that our goal is to produce healthy adults. Maybe you really are only interested in healthy children. But I would argue that you should still care about education, even if we back our timeline up all the way to childhood over here. So for one thing, there are well-documented intergenerational associations between parental level of education and child health. So this here is data from the National Centers for Health Statistics, and this just describes infant mortality by maternal level of education in the US. And you can see that as maternal level of education increases from having less than high school education to being a high school graduate, to having attended some college, and to graduating from college, infant mortality drops dramatically. But perhaps more importantly for us as pediatricians, we also know that how our patients perform in school is tightly linked to their health behaviors and outcomes in childhood and adolescence. So this is data from the Youth Risk Behavior Survey, which is a national survey of high school students. It's administered by the CDC. And in 2009, as part of the survey, they had participants self-report what grades they got in school. And as you can see, across each of these outcomes, whether it's carrying a weapon, using cigarettes, using alcohol, being sexually active, having lots of screen time, or being physically inactive, students with better grades have better health outcomes across the board. And again, these relationships have been seen repeatedly over many, many samples. So when we put together what we just discussed about how education relates to child and adult health, you can see here on the bottom the pathways we talked about before, linking education to adult health, those cognitive resources, material resources, and psychosocial resources. And then you can also see this idea that healthy children actually support the development of healthy adults. And then the other thing that I want to acknowledge is that there are a whole host of factors that probably make it both easier for a child to do well in school and also helps them be healthy. And many of these are things that we look for in our families when we're trying to identify who the most vulnerable children in our practice are. So these are things like having a developmental disability, living in poverty, or being exposed to violence, for example. But even after you control for a whole host of these factors, and people have really tried hard to sort of explain away this association by accounting for those factors, there still remains a really important link between school function and child health. And when we think about what the potential mechanisms are that explain this link, we have to look to other mechanisms than what we discussed before. It can't be that it's access to a better job or employment, right? It's got to be something else that impacts child health. So 2 of the mechanisms that have been proposed that I'm going to spend some time talking about next has to do with identity and social networks. So broadly, this refers to the idea that how kids do in school shapes how they think about themselves and who is in their social network. And then those things go on to shape their health behaviors and outcomes. And for the next few minutes, I'm going to just delve into this relationship, this part of this education and health relationship a little bit more. For the purposes of this discussion, in terms of health outcomes, I'm going to focus on substance use, which we know is both common and also has negative downstream effects and can lead to poor adult health. So first, I'm going to show you a couple different ways that we've tried to understand this relationship between school environments, identity, and substance use. And one way to define identity is self-concept. Self-concept technically refers to the self-evaluation of one's competency in different domains. So, for example, my academic self-concept is whether or not I think of myself as a good student. And my behavioral self-concept is whether or not I think of myself as well-behaving. Both academic and behavioral self-concept have been associated cross-sectionally with academic achievement and substance use in a number of different studies. And we think that self-concept is formed by getting feedback about basically how you rank in these different domains. And the more valued the source of that feedback, the more it impacts how you develop your self-concept. So if somebody that's really important to you gives you messages that your behavior is poor, that's going to be more powerful than somebody giving you that same message, somebody who's not as important to you. So one really important thing to understand, and something that we wanted to tease out, was whether self-concept actually motivates substance use or vice versa. Does substance use motivate self-concept? Does how you think about yourself determine your health behaviors, or do your health behaviors affect how you think about yourself? So to tease this out, we surveyed 291 students at Venice High School in the fall and spring of their 9th grade years to see whether self-concept preceded drinking behaviors or vice versa. And what we found was that baseline self-concept predicted the odds of binge drinking and at-school drinking at follow-up, even controlling for baseline drinking behaviors. And in addition, baseline self-concept predicted the type of drinking behavior such that students with the lowest self-concept in the fall had increased odds of engaging in more risky drinking behaviors in the spring after controlling for the riskiness of their fall drinking. And then we looked at things in the reverse direction, and in contrast, we found that neither the frequency nor the type of drinking in the fall predicted self-concept in the spring after controlling for baseline self-concept. So taken together, this does suggest that self-concept precedes those behaviors. Another way that we've tried to look at identity is through this age-old question of what do you want to be when you grow up? This is a question that I've always asked patients, mostly in an effort to sort of just build rapport and get to know them better. And I always found it a little disconcerting when they didn't have an answer for me, when they said they didn't know, they weren't really thinking about anything. So although I found it disconcerting, I thought, well, okay, I don't want to just go based on my gut feeling. So I actually went to the literature to see if there were any studies to support this idea that it was really important to have a career aspiration. And surprisingly, there was basically nothing out there that looked at what this question means. So, we asked, what does it mean? What does it mean when somebody doesn't have a career aspiration, or when they say that they would like to be a rapper versus a neurosurgeon? What does that tell you about their health? There are a number of potential reasons why career aspirations might be important to adolescent health. First, there is some evidence that just having goals to work toward are associated with lower rates of risky health behaviors, especially behaviors that might get in the way of reaching those goals. So something like substance use. We also know that hopelessness about the future and having a low sense of self-efficacy, which is how confident you are that you could reach a goal, those are both associated with risky health behaviors. And then finally, some people think that our behaviors are strongly influenced by something called archetype matching. So archetype matching is this idea that people hold archetypes in their mind and think about how an archetypal doctor would behave versus an archetypal rapper. And then they match their behavior to the archetype that fits them best. We know from both qualitative and quantitative studies that archetype matching is associated with a whole host of behaviors, including health behaviors. And in fact, it's one of the main things that marketers try to tap into when they try to get you to make purchasing decisions, is they try to tap into you trying to match your behavior to an archetype of something that you sort of aspire to be. So to understand whether this question of what do you want to be when you grow up was associated with school performance, we looked at survey responses from 929 Los Angeles area high school students who were participating in the RISE study, and I'll tell you more about the RISE study in a little bit. So for this analysis, we recorded verbatim what students said when we asked them, what do you want to be when you grow up? And then we used data from the Bureau of Labor and Statistics to find what the entry level of education would be for them to have that career. And then we also looked at what their median income would be if they had that career. Finally, we looked at the prestige score associated with that career, and prestige scores have been developed by social scientists to account for the fact that some careers have low levels of education and low incomes, but are relatively highly valued in society. So this is something like a firefighter who maybe doesn't need much education, doesn't earn a lot, but is well respected. And then separately, we looked at those kids who didn't have an answer when we asked them and said, don't know. So we found that after controlling for sociodemographics and school quality, career aspirations were associated with school performance, such that kids with better grades aspired to have careers that required more education and with higher median income levels. And then we looked at hopelessness and self-efficacy, and we found that regardless of which way we measured career aspirations, after controlling for sociodemographic, school quality, and individual academic achievement, low career aspirations were associated with hopelessness and lower self-efficacy. And having no career aspirations was associated with hopelessness, and although just barely not statistically significant, there's a trend towards also lower self-efficacy. So finally, we looked at those students who had high grades but named a career that required very low levels of education. So something like being a singer, a professional athlete, or a police officer. And we looked at those kids who had low grades but aspired to have a career that required high levels of education, like being a doctor or a lawyer. So compared to those whose aspirations were more consistent with their grades, students with high grades and low aspirations had an increased odds of engaging in substance use and delinquent behaviors. But in contrast, having high but potentially unrealistic aspirations was not associated with an increased odds of engaging in these behaviors. Now, to better understand this, moving forward, we plan to look at longitudinal data to track how career aspirations change over time relative to school performance and risky health behaviors. So to bring us back to our model here, we've talked about this relationship between identity and substance use, and how school function and identity are related as well. And now I'm going to talk a little bit about social networks and how they might be a potential mediator between school function and adolescent health. So we know that adolescents' health behaviors, like substance use, are closely tied to the behaviors and attitudes of their social network. And this is true for both peer and adult networks. Social networks are really quite powerful because they determine the amount of social pressure and social value of engaging in substance use, as well as access to those substances and even the opportunities to use them. And if you think about it, peer networks are often tied to the schools that kids attend, and even within those schools to the classes that they get assigned to. So while you might initially become friends with someone in your AP English class versus your remedial English class, those friendships can positively or negatively reinforce academic and health behaviors. So although I've been kind of using this linear model to go through these relationships, actually social networks are almost like an engine of a school environment that can drive academic and health behaviors in this downward spiral. Kids with poor school function are grouped with similar students in remedial classes, and that reinforces low academic and behavioral self-concept, and it also produces an environment where risky health behaviors are highly valued and school engagement is not. So the question is, can schools break this cycle? Can schools use this influence that they have over social networks to alter this and reverse that downward spiral into an upward one? So experimental or quasi-experimental studies looking at this are incredibly limited, but there are a couple out there, and they suggest that this might be possible. Hopefully many of you know about the Harlem Children's Zone. This is Jeffrey, Canada. And if you aren't familiar with the Harlem Children's Zone, I encourage you to learn more about it. There's a couple really great books written about this. The Harlem Children's Zone is a 97-block neighborhood in Harlem that combines really intensive neighborhood social support with high-quality charter schools. And these schools were depicted in Waiting for Superman, and they place a really high value on academic performance, but they also intentionally try to shape self-concept. And they provide students with these long-term relationships with supportive adults. Entrance into the charter schools is based on a random admissions lottery, while eligibility for that whole host of neighborhood support services that go along with the Harlem Children's Zone is based on where residents live. So it's based on their home address. So to try to isolate the impact of attending these Promise Academy schools, these charter schools, from the other neighborhood supports, two researchers, Dobby and Fryer, compared survey responses from lottery winners and losers living inside and outside the Harlem Children's Zone. And they looked at their health 7 years after that initial lottery to get into the school. And they found actually pretty large gains in academic outcomes. So on the y-axis here, this is standardized. So this is the basically effect size, or how many standard deviations they saw in the outcome. So you can see that this human capital index, this is an index of it's kind of a summative index of education outcomes, and they found really large gains there, just shy of a third of a standard deviation. They also found improvements in risky health behaviors. So this is captured by this risky behaviors index, and it includes pregnancy, incarceration, substance use, and criminal behaviors, and it amounts to 0.14 standard deviations, which is still substantial. Specifically, just to give you some perspective, girls who won the lottery were 12% less likely to be teen mothers, and boys were 4.3% less likely to be incarcerated. They did not see significant improvements in other health outcomes like healthy eating, mental health, and physical health. And they found that these effect sizes were equivalent when they looked at lottery winners living within the Harlem Children's Zone and those living outside the zone. So that really suggests that the active ingredient here was the school environment. The next study I'm going to tell you about is the RISE study, which was led by Mitch Wong here at UCLA, and which many other folks here worked on, including colleagues in internal medicine, child psychiatry, folks from RAND, and from Pediatrics. Paul Chung was involved. And RISE used a similar approach to the Harlem Children's Zone study, studying the effect of high-quality charter schools on academic and health outcomes. This was a cross-sectional study of 929 youth who had applied to high-performing charter schools serving low-income communities here in Los Angeles. Survey responses from lottery winners were compared with those from lottery losers, regardless of what school they attended. Once again, winning the lottery was associated with better academic achievement, as measured by standardized test scores and school dropout. But in addition, lottery winners had lower odds of engaging in very risky behaviors like substance use, gang involvement, and risky sexual activity. And because the RISE study included measures of self-concept and participants' personal social network, we were also able to look at specific associations between social networks, self-concept, and substance use. So we first tested whether relationships with teachers or coaches were associated with academic and behavioral self-concept, and found that reporting more supportive teachers, interactions or relationships with more supportive teachers, and naming more coaches in one social network were associated with better academic and behavioral self-concept. And I should mention that these models control for the larger context that adolescents experience. So we controlled for their family social network, their peer network, as well as a bunch of sociodemographics like their gender, grade, their ethnicity, socioeconomic status, and their individual GPA and the quality of their schools. So we tried to really account for a lot of the other things that might come into play here. Then we looked to see whether these same measures of school-related adult support were associated with substance use. And you can see that this was the case for both teacher support and number of coaches. So finally, we tested whether this association between relationships with teachers and coaches and substance use is mediated through self-concept. So you can see that academic self-concept mediated 13 to 28% of these associations between teacher support and substance use, while behavioral self-concept mediated 34 to 62% of the association between teacher support and substance use. And then similarly, behavioral self-concept mediated 19% of the association between number of teachers named, number of coaches named, and marijuana use. So overall, this suggests that it may be the case that relationships with teachers and coaches and other supportive adults impact substance use in part by helping teens develop a healthy sense of self-concept. To get a more complete picture of this process, we just completed a qualitative study with 32 former RISE participants who had all completed high school. And we asked these youth to tell us how they came to be the person they are today and how their experiences in school shaped that process. And then we asked them how their sense of identity influenced their substance use decisions. Because all of these participants had taken the RISE survey 2.5 to 3 years earlier, we were able to specifically recruit youth who at the time of the RISE survey reported both healthy and unhealthy self-concepts and who engaged in substance use and abstained from substance use. So in general, youth describe this process where specific aspects of their school environment influence their relationships with their peers and school-related adults like teachers and coaches. Those relationships impacted their academic and behavioral self-concepts, which went on to affect their decisions around substance use. So to give you a better sense for what aspects of the school environment participants talked about with respect to this process, I'm just going to share with you some of the key examples of what folks said. So this is a participant who's describing the impact of being programmed into more challenging courses through a college preparatory program at her school. She went to a public school. She says, "It's just like a different crowd of kids, you know? They're not the type to say, hey, let's go smoke, let's go drink, or let's go do something bad. They're more like, hey, let's go out to eat, let's go to the park, let's talk about college or what our goals are. You had more support from the teachers, and I think they saw you differently because they saw that you cared and they wanted to help me out." And this participant talks about how her coach had a major influence on her at a vulnerable period in her life. And just so you know, I've changed her name in this quote just to maintain her privacy. She says, "Yeah, there was my coach, my basketball coach. There was a time where I guess I started hanging out with the wrong people and they influenced me to smoke. And then he pulled me aside and he was like, Josie, I've seen what you were doing and it's either them or basketball. I was like, okay, and I went with basketball." Here, this participant talks about how he decided on the second day of attending one of these high-performing charter schools that he would have to change his identity to fit in with the school culture and norms there. He says, "I had to act and adapt like a smart kid to be cool like everybody. Because over there," he's talking about his middle school, you would have to be acting up or doing drugs to be cool. Over here, it's either you do your schoolwork to be cool or you would be the weird kid. And then here a participant reflects on how closely students are watching how adults at school treat them and how important those personal connections are to making kids feel supported. He says, but I know that sometimes, like expectations, the way teachers perceive students is detrimental to their outcome. I've come to realize that students are pushed out of the education system. They don't drop out themselves, they're pushed out. And I find it so fascinating how a student at my high school, you can go there for 4 years without a teacher knowing your name, without a teacher remembering who you are. So one thing that really moved me was that in all of these interviews, never was there a moment when a child could not tell me how the teachers at their school thought of them. They're really paying close attention to how adults, the messages that adults are sending them. So these interviews really motivated me to think about how we could leverage this power that schools have over social networks to actually try to shape their substance use. So what I hope to work on next is a randomized controlled trial of this program called AVID, which is actually the program that first quote that student participated in AVID. So AVID takes kids from high-risk groups who are middle performing students, so students who have like a 2.0 to a 3.5 GPA. And they make sure that these kids get programmed into college prep, honors, and AP courses while providing them with academic and social support. And just like in the Promise Academies, AVID is actually focused on changing how kids see themselves and tries to bring students into what they call the AVID family of supportive teachers, college mentors, and peers. So the idea, and I hopefully will have the chance to test this out, is whether participation in AVID changes students' social networks and hence their substance use. So we've gone through this little tour of how education and health are related, but before I close, I just want to wrap up with a quick discussion of how we might apply this knowledge in our own clinical practice. So if you believe my argument that good academic outcomes are key to achieving good health outcomes, then we should really be focused on doing what we can as pediatricians to promote academic achievement. So this means, number one, promoting school readiness from birth. And we have a whole host of evidence-based practices in this area that we should be doing, and many of us are doing this, as part of our daily practice. So this includes developmental screening and surveillance, connecting those children with a deficit to early intervention, programs like Reach Out and Read, which we know improve early literacy skills, connecting children to early Head Start programs and Head Start preschools so that all children have access to those high-quality preschool experiences. And then once our kids are in school, we should be focused on supporting their school function. At every visit, we should be asking them how they're doing in school and what kind of grades they're earning. This also means paying special attention to those kinds of healthcare services that we know are directly linked to school function. So these are things like mental health, vision care, dental care, surprisingly, and family planning is huge for our adolescents. And then I would argue that we should also really try to limit the number of times kids have to miss school, both due to their health conditions and also to come see us in our clinic appointments. Whether that means coordinating care for complex kids who have multiple doctor visits so they can all happen at the same time, or offering appointments outside of school hours. And then when we do identify problems in school, we need to really help figure out why that is so we can help our patients succeed. Sometimes this requires directly communicating with the school to get to the bottom of the issue and coordinate care, and our education and health systems are not set up to really do this well. So one very successful model for doing this was developed by Alice Kuo here, called the School Function Clinic, and she uses a social worker to help facilitate this communication between education and health practitioners. Another model for integrating education and health systems is school-based health. And there are some really exciting things happening both nationally and locally in the Los Angeles Unified School District around this model that a number of folks here have also been working on. And then finally, we should be using our voices as child health advocates to really advocate for healthy schools. So whether that means, just voting in the school board election or trying to shore up school funding to make sure that our schools have the resources they need to support child development, those activities are really important. So hopefully I've convinced you through the course of this talk that education policy is health policy, and that by fighting for better school environments, we're actually helping to support health through childhood, adolescence, and adulthood. So I just want to thank my mentors and collaborators, many of whom are here today. Thank you. So they're kind of listed here: Paul, Chung, Mitch Wong, Bergen, Tamani, Chris, Ning, Giselle, Grace, the students at Venice High School and teachers there, and all of the study participants, and then acknowledge my funding sources through the UCLA CDI and the CTSI KL2 program. Thanks.